Hello, everybody. My name is Rajat, and thank you for joining us for the next installment of the Clinical Education Committee's research lecture series. So, veering off the traditional path of our curriculum, we have a very special talk with us for this evening. Often as trainees, medical students interested in interventional radiology, we're faced with the fact that our field is a very innovative field, especially with regard to devices, which goes hand in hand, of course, with clinical research. But often when we have an idea in our head, we don't know what to do with it. So we're very lucky to have here tonight David Chen from UVA. David Chen received his master's in cell and developmental biology from Rutgers University in 2002. He also received his MBA from the Darden School of Business at UVA in 2006. Currently, he's a biomedical engineer in the Department of Biomedical Engineering at UVA, where he's the director of the Coulter project, which is an endowment to support translational research. In addition to these responsibilities with the Coulter project, he also instructs BME Advanced Design. He mentors students design projects, and he leads the School of Medicine program, Medical Innovation and Human-Centered Design. So without further ado, David, thank you so much for being here with us tonight, and everyone's in for a real special treat. I just want to remind everybody this will be on YouTube, so you can access it at any time, and you can post your questions in the question box at any point, and David will answer them at the end. David, thanks a lot. You can go ahead.
Sure, Rajat. Make sure that you hear me all right and see me all right and see my screen.
Yeah, I think we're good. I can see your screen.
Okay. The control panel's here a little bit. I'm going to see if I can move that over so you can get the full thing. All right. So, Rajat, thank you very much. Tonight will be definitely more of a discussion format. Do have some content to share with you all. And I don't have an easy way to toggle the screen share, but if you have questions, definitely ask them in the chat, and hopefully we can get to those. So, yes, welcome. So brief introduction. Thank you, Rajat. As you mentioned, I do run the Coulter Translational Research Program. I'm also, we just started a new program in Medical Innovation, Human-Centered Design, teaching med school students about design and design thinking. I co-instruct that or co-direct that with Dr. Matt Trowbridge and Dr. Eric Hewlett. And I'm also a lecturer in biomedical engineering, teach mostly undergrads. Just a little bit about Coulter. So we're actually one of 15 schools across the country. Other schools include Georgia Tech Emory, University of Michigan, Stanford, Johns Hopkins has a program. So some of you might be training at those centers. If so, feel free to reach out to me, and I can always send you along to a Coulter person or find them yourself, no problem. So the program at UVA was established in 2006. We were fully endowed at $25 million, or $20 million at the time, 2011, to support translational research here at the University of Virginia. Each of the Coulter programs, we support projects at our specific schools. The outcomes are all about clinical impact, but many times our philosophy is we see that impact via commercialization. It's not a requirement. We're not out to make money. When a company does well, we do not see any monetary gain. However, we do see the commercialization avenue is critical to realizing positive clinical impact. So over the last 10 years, we've supported over 60 projects, resulted in 15 startups and 10 licensing deals. On the right of the slide, a couple of companies that started, Neoenergetics, Ravana, EpiEP, TypeZero. Those are just a couple of our companies that we've done, and it's been a great fun being here at UVA doing that. So through that, also oversee or help the UVA Medical Device Design Group. I have to edit these photos because this will be on YouTube and therefore considered a public disclosure, although this audience would be considered that as well. So we have different ideas. We work with surgeons and proceduralists. A lot of our work with the undergrads will be to help with their design sketches, some of the things that we'll be talking about today, and a lot of drawing and sketching and iterative design work. So briefly about Coulter, and a lot of what I'm going to be talking about today is that design and innovation and invention is the process. And the Coulter Foundation is very much, the program is very much a process. So very briefly, it starts with idea generation. We go through risk assessment, project selection by an external board, risk reduction through funding, and killer experiments, and then follow-on funding, which is our ultimate metric. Did the technology or the project result in either a startup or a licensing deal? Briefly on the medical school human-centered design program, we emphasize human-centered design process. It's a sort of a nuance in the type of design approach. It's hands-on and very experiential. We focus our training during first 2 years of medical school. And just last year in 2016, we focus on high utilizers in the clinic and patient falls within the health system, both very important elements to our Be Safe initiative. 2017, we're looking to maybe spend some time in the emergency room, although the opportunities continue to grow, so we're still assessing some of that. So on to the talk, what do you do with an idea? And this is something that through Coulter, I've worked with a lot with clinicians to see problems and challenges, and then also through my medical school program, often talk with medical students who are shadowing or scribing, and they see all types of opportunities, all types of challenges in the clinic. Through a talk at SIR this past spring, also just see so many examples of this, and so I'm very happy to be here to talk a little bit about what we're learning about this process. So as I mentioned, invention design is very much a process. It's not a eureka moment that occurs to you. You all probably hear this time and time again when people talk about Thomas Edison or even great clinician inventors like Fogarty or other folks in various fields. It really starts with identifying the need, and then through that process, many times a very rigorous investigational process, generating, well, filtering those needs down, and then moving on to generating concepts, and then creating strategy to develop and plan. We're going to have a second session on protecting your idea and intellectual property, which we'll spend a little more time on later, and I think that's on cue for that. We're on cue for that, right, Rajat?
And Telly,
yes, we are.
Okay, so that's going to be in July. So what happens many times is, in terms of identifying the need, is when people are not necessarily trained in the process, they come with a great idea, a great solution. And one of the many elements that's really important in design is to separate that solution from that need. And so starting with the very basic core of that need, really, really trying to build it around terms of the clinician, the clinical and the patient is really, really, really important. So a lot of human-centered design, a lot of the biodesign process discusses this. So this is the biodesign process. This is a program at Stanford. Some of you might be there and be training, and they spend a lot of time. So the Biodesign Fellowship, full fellowship, is a full year. Many times people have already received their MDs or have completed or in the middle of their residency, so perhaps something that you all could look into. They put people on cross-disciplinary teams, engineers, clinicians, and some business folks. It's a full year, full-time process, so that should give you a little bit of a sense of the intensity of training and the intensity of learning required. So the biodesign process, if you were to Google it, I have some web links at the end of this presentation that you can always look up and click through that I found very useful. Starts with needs finding. And then there's a very rigorous process around needs finding. They typically go into the clinic and talk to people. Many of the things that you all are doing perhaps very naturally, just being in your training years. The part that is really important is also the needs screening. So needs screening would be talking to mentors, doing your diligence, researching, reading clinical papers, and seeing if that need is a legitimate need, or if it's something that is operator dependent, perhaps unique to your experience. We see this all the time in our basic experiences, non-clinical experiences, just in terms of our phones and technologies we use. But of course, you also see this when you're working with patients and taking care of them. Following the identification, as I mentioned, similar, you go into the invention phase. Again, separating the identification from the invention, which is really important to the process. You work on your concept generation, and then you also do your concept screening. So if you notice on some of the slides or the slide, it's a very iterative process. It's something you hear a lot in design. It's not a, well, I came up with this great moment, this great solution. It's actually very much a cycle where you're identifying needs, you're screening your needs, and then that knowledge is then pouring back into the identification of additional needs. And then you move forward to concept generation, but sometimes you have a hard time generating feasible concepts, and then you have to go back to your needs finding, your needs screening. And then moving forward, you're developing your strategy and your business planning, but sometimes you also hit enormous challenges, maybe intellectual property that is blocking, perhaps opportunities that be exceedingly hard to overcome. So you have to go back to the previous steps. This speaks to why it's such a rigorous year-long process. Probably a little bit much for you if you're in the middle of your training, but in terms of the discipline for the needs finding and the needs screening, I believe that there is very much an opportunity in a place where you can spend some time putting those ideas together. So another platform or another school of thought around design is the human-centered design process. So IDEO, a firm out of Palo Alto, many Stanford Design School graduates, where they started, or co-started IDEO, and many books have been published around this. So this is their newest materials, courtesy of their website. Actually, their design handbook is free. You can download it as a PDF. So they start a lot with empathy and inspiration and really trying to understand the user needs, create a design challenge. And then through that, you have ideation, and then that refines your further inspiration and then implementation. One of the elements I think that's really important that IDEO and the human-centered design process discusses is it's called a double diamond, or it's essentially, if you see the sort of roller coaster ride down here of orange, blue, and green, is you have divergence of ideas. That means trying to create as many opportunities, being open-minded to new ideas, and then filtering, converging, and then diverging again, and then converging. It's very similar actually to the biodesign process, where you're finding, and when you find, you are trying to be as open as possible to opportunities. You're trying to not filter them yet, but then the next step would be to filter them for feasibility. Again, that's something where many times people will sort of create an amalgamation process where they're creating a solution while they're discovering the need. And that sometimes that co-creation process can be extremely dangerous because you're convinced that the need is there, and this is the solution for that need, but you haven't done a rigorous research, an investigational process. So these are two sort of well-published, processes that I encourage you to investigate and use. We sort of, in my classes, combine both of them, but each of them definitely have their strengths and weaknesses. The biodesign process is definitely more for a medical type of application, device-oriented. IDEO and this human-centered design process is more generic, but it's very, very useful for a lot of the patient work that we do. So I think it's very valuable and important for you to know. So a couple things. Needs are not solutions. So again, when you identify a need, you should really be articulating what the desired outcome is, what you're trying to improve. think one thing that's, for busy residents, things that you can do, take the time to write down the needs you observe. This could be as simple as a way to make, decrease excessive bleeding, a way to reverse a procedure, a way to make something more efficient, more manageable. These are sort of general areas that you can sort of consider during your time on service on clinic. Doing research really helps. I think sometimes even doing 15 minutes to 30 minutes of research, especially with your background and your training, can help tremendously to define the need a little better. I've worked with medical students who've are incredibly efficient with reading papers and different types of outcomes research, much further than my biomedical engineer undergrads. So I'm sure at your level you can hammer through a good number of papers and sort of see if the need's legitimate. And what sometimes you'll find that a paper in the 70s, a group out of whatever, Johns Hopkins or Columbia has already done it, or a group out of Europe has already tried something. And that'll really help you with your refining process. You don't want to waste your time investigating a need that's, maybe not there or has been investigated at one point in the past. It's also great to ask around to colleagues. Sometimes people, similar training programs or training programs at other institutions are a great way to see if that need that you observe is just something you've seen from your standpoint or your institution, or something that's sort of a broader need that you see everywhere. Design is really a team sport. You really need a lot of support, a lot of people to help, and often it's very easy to be convinced that your idea is fantastic. So talking to others at this stage is really, really good way to engage in the process. One of the things that we're going to be talking about during the next session is how to protect your ideas and intellectual property. A clinical need is not intellectual property. A clinical need is a clinical need. So asking how patients are handled, asking how to improve certain outcomes, that's not the same thing as discussing, a widget idea that you might have, after going through this process. So this is usually where I really encourage clinicians and my students to engage as many people as possible. And of course, research that you're probably very accustomed to doing all the time, UpToDate, PubMed, Ovid, et cetera. To do your research is, a great place. And just really focus on the clinical problem at this stage, versus a technical, highly technical need. That's where your expertise is. That's where my engineering students and my engineers need to talk to clinicians in terms of patient care. And so that's knowledge that you already have at your fingertips and what you're training for. So some classic tips, I guess, for need statement development. This is particularly true for some of my favorite engineering students and senior researchers, is beware of fancy technology defining the need. Analogies that we like to use are, beware letting, don't let the tail wag the dog, or, this is a hammer looking for nails, kind of like, to a hammer, everything looks like a nail, and all you're trying to do is hammer things in. Really let the patient needs, let the clinical needs define what needs to be done. And again, that's something that many of you would be very adept at doing, although I guess sometimes proceduralists can really, really love technology or get excited about that. So just be aware of that. Isolating to a single need is also a really important discipline. Sometimes there's this tendency of trying to combine so many needs into one need statement, and that becomes very dangerous, but also very really affects the feasibility of whether or not your technology or your idea can move forward. We're not talking technology yet. And so be specific and quantitative in patient populations and clinical outcomes. So really drilling down is really important. So need statement development is really, it's a lot of science and technical, but it's also a little bit of an art. And if you were to go through the Biodesign program or have mentors who have done those programs, they can really help guide you through that, through the development. A couple of things that, just courtesy of the Biodesign program, that also helps a lot, just to wrap your heads a little bit around outcomes. So, improving clinical efficacy, might be a success rate in a trial, or increasing patient safety, decreasing adverse events in a clinical trial. Reducing cost would look like a comparative cost analysis. Improving productivity is like a time and resource analysis. Ease of use might be making workflow more simplified. Patient convenience might be frequency of changing or treatment or returning to a treatment venue. Patient recovery, decrease of possible stay, recovery period, etc. This is just ways to sort of try to drive towards quantitative metrics versus saying increasing patient safety. It's like, well, what does that actually mean? How would you actually measure that? Increasing convenience. That's one that my students say all the time. It's like, well, we want to make it more convenient. It's like, well, how do you measure that? How is that meaningful? How does that translate into a doctor, a proceduralist saying, I want this? Well, might be frequency of, treatments or retreatments, etc. So the second step would be generating concepts. So generating concepts, this is usually a really fun part. It's about brainstorming, and similar to what I earlier, trying to get as many ideas initially is pretty fun. I really enjoy this part, and it's literally the sky's the limit. Like, if we can send a patient to a sub-gravity environment, on Mars, and then fish them back and do the treatment there, it's like, that sounds completely crazy, but this is the step where you can be really open-minded about your ideas. Being visual really, really helps in this step. I've worked with a lot of clinicians, and you all have built your expertise around taking care of patients, probably not sketching and drawing, but any sketch that you can do really, really helps. So putting that down, and if you can really put that down with anatomy, that helps an engineer who is just typically not thinking about anatomy unless they are a designer that works specifically in this field. So being visual is incredibly useful, and it's okay to feel a little ashamed about it, but it really gets the idea on paper, and it really gives something for someone to react to. So capturing the concept is really good. I think at this stage, when you're generating just general concepts, perfection is the enemy. It's probably impossible to get it right. You're just trying to get your idea down on paper and to be really open about it. And it'd be great to write a design brief at this point. So a design brief is basically something that describes the desire or the need of the design, not the design itself. And it takes a lot of work, just like developing a need statement on what that design brief would look like. But that's something that you can look up online and sort of read about. And just being able to write down a design brief so you can articulate to a materials engineer or designer or someone that you know really goes a long way. That drawing, that physical drawing, and then someone can do a digital rendering and then sort of start talking about feasibility and building something. And it's just, it's incredible how much efficiency, how much time is saved by doing that really simple step of saying, I drew this really simple catheter or this, vena cava filter, and here's what I'm thinking about. And it's like, oh, okay, I get it. I understand that, versus talking in sort of circles in your head about what something should look like. So strategy development and planning, the third part, at this point, it's really good to also engage some people outside of your field, lawyers, mentors of your program, business folks, to talk about funding, to assemble a team. So if you've really done a good job in the earlier steps of doing your research and generating concepts, you should have a pretty good idea at this point. So it'd be really good to engage some people outside. A lawyer should be high on the list of people you want to talk to, because you want to see if your intellectual property or your idea is protectable. Mentors of your program, business folks are also really good, because you have a little bit more solid ground for you, for what your idea is. And like I said, here's some resources. I guess I can ask Rajat to provide this slide deck to everybody so you can take a look at those resources there. So yeah, that's actually kind of flew through that a little faster than I realized, but we can definitely unpack a couple more points. Very happy to go through this a little more, but I think I have a question here.
David, thanks so much. Extremely beneficial information. We do have a few questions. First one is from Daniel Crawford. He's asking, what tools can be used for need screening? That is, if
Mm-hmm.
10 legitimate needs are identified, how do you decide which need to pursue?
Yeah, that's a really good question, and it's something that if you were to go through the program, they spend a lot of time talking about the different criteria you would use. I think some of it starts with what your goal is. If your goal is clinical impact, and you're okay, you're not necessarily out to make a lot of money. You want to continue in your clinical practice, focusing on building your practice areas. Then the end goal might look like a licensing deal, or maybe a new way of applying a tool or an existing tool to maybe your center. This happens a lot where how something is handled or managed at a Memorial Sloan Kettering is not the same thing as a UPA. So I think it does help to know what your goal is, but generically, I would say typically, you want to think about needs that are, so let's say you want to do a startup, a clinical need where you're trying to improve something by 1%. If you're looking at a startup and a business opportunity, that's a really small number, typically. Now, 1% of a big number sounds like a big number, but if you were to translate that into a clinical trial where you have to do, a 5-year outcome study, that could be a very long trial. It's very expensive. So it kind of starts with what you have in mind in terms of the end goal, and I think feasibility should always be an important criteria, even at sort of a need statement level, where it's like, well, we want to improve this outcome for, let's say, this patient population by X%. It's like it's a very frail patient population, for example, or an incredibly fragile, or maybe or even the other extreme, a barely at-risk patient population. You might run into some feasibility sort of questions very quickly. So there are some resources if you were to look at the Biodesign or talk to some of your mentors. Sometimes it's also guiding you, on what those important criteria are in your needs screening. But what's really good is, I think the important part is being mindful of having a lot of need statements. And if you were to sort of over time write down all these different areas that you're interested in, I think things that you're personally interested in working on are, with your limited time, are also sometimes a really good screening sort of tool. So it's a little personal. It's also, maybe lastly, resource dependent. If you're at a place where there are resources, funding, you have percent time that you're allowed to pursue something, that might allow you to pursue more need areas or more ideas, versus if you're incredibly strained and an institution that doesn't have a lot of funding or support for these types of things, then you have to be much more selective. So I don't know if that answers the question directly. It's a little bit of a it depends type of answer, but hopefully it gives you some things to think about.
Daniel, you can let us know if that answered your question in the chat box, and if not, we can ask a little bit further. So just to answer one of your previous questions about previous experience, David, Daniel was actually a device development engineer for Gore for 6 years prior to entering medical school.
So he's asking a trick question because he did this at Gore for That's good, and that's awesome. I wish I caught that earlier at your background. I mean, I would say, because based on that experience, I think you probably have a really good handle on like feasibility, and it's like, is it a licensing opportunity that's going to drive a very different set of criteria than a pure startup. Again, happy to talk more about that separately if you'd like. But it's a really good question.
So our next question is from Jasmine Koo. She would like to know, how do we get information about materials for the product?
Okay. People who worked at Gore would know that. So a couple things on that. So in terms of final product, there are pretty strict guidelines on testing, duration of use, different sort of, is the material contacting, is it blood contacting or skin contacting? There's a lot of criteria that the FDA follows around testing. And so what we found is that there tends to be sort of a handful of materials that are used over and over again. We're running into this with an idea we have for an implantable of the heart. And we're looking at, we'd like to use a stainless that has a high ferrous content, but that's not used very often in the body. And so part of it is from a sterility standpoint, part of it is from a long-term duration, in the body sort of standpoint in our intended clinical use. So the short answer is the best places where I always go are design firms. So there's a couple of contract manufacturing design firms. A really good one based out of the Bay Area in Colorado is Invention. They do a lot of balloons. They also do a lot of catheters. We use Medical Murray. They're based out of Chicago, but they have an office in North Carolina. They've been a fantastic resource for us. The stainless question we asked a group called Cadence out of Virginia because they do a lot of in stainless. It tends to be, the medical device industry is sometimes a very cottage industry, a lot of specific small groups that do certain types of materials and have a lot of knowledge and manipulating those materials. And so a single compendium source is available if you're a device manufacturer, but most clinicians don't have access to those. So one thing I guess you can always do is ask your sales rep or ask an clinical engineer that represents the company. If you don't tell them the phone, you can always ask hey, do you have experience working with this stainless type of stainless material or this type of this particular type of metal? That's actually a great way to learn a little bit. In terms of a single source online, we typically ask sort of as a per material and per criteria standpoint. And again, you'll find that the FDA, because of the criteria and strict guidance, they tend to use the same things over and over again. There's always new, ways of treating materials and sintered metals and orthopedics, for example. New types of biologics, biomaterials are being used, but the innovation is actually pretty slow going.
Got it. Thanks for the question, Jasmine. I hope that helped. The next question is from Chris Lind. He would like to know, how can I determine if the frequency of a complication is similar at a regional and a national level?
That's a really, really good question, and one that you run into a lot. I worked at St. Jude Medical for a little bit of time. We had a lot of interest in, at that time, hypertension and areas of heart failure, classic areas that many cardiovascular companies have been interested in. And we found ourselves constantly reading papers, comparing outcomes, looking at Framingham study outcomes to looking at national registries. And so, the first place to go is always some sort of national registry, some sort of national study that the NIH might be sponsoring. Those are still very sort of survey-based. They're not comprehensive, but they're a great place to look in those sort of review papers. What's so challenging about academic publishing and papers is that it would be great if someone could repeat that study exactly, but that's not always publishable or fundable. So you have to always put a unique twist, a unique sort of search for that new knowledge, and it makes comparative studies really, really hard. Locally, what's awesome is that most of you have access to, at UVA, we have a clinical data repository, so you submit an IRB, if it gets approved, then you can do queries locally, and UVA being a regional hospital has some really, really good regional data from patients. So it depends on the institution you're at to get some of that regional data. But it's a great question, and that's something that we always look at our national registries, sort of big publication houses, big papers first. And if it's not in there, then unfortunately you're sometimes stuck trying to sort of fill in the gaps of knowledge in reading papers, which might be a good undergraduate intern task to do under you, since you're probably very busy training.
Thanks, David. I hope that helped Chris. So we're getting many thanks here. We are actually getting many requests. If you could just put up the resources slide again, they would like to see the resources
Yeah.
slide. And while you're doing that, just another couple questions. You talked about, doing like maybe 15, 30 minutes of research on your own. So say you have a great idea, you do the research and you come across something that already exists, but you think maybe you can develop upon it a little bit further, make it a little bit better. What do you do at that point?
Yeah, and that happens all the time. Actually, a couple of the device tools that we've been working on with proceduralists are small improvements to, maybe procedures they do all the time. And, we're really seeking a licensing deal or a way to license that technology to a J&J or Covidien or whoever, Bard. Let me see if I can get that question right here. I want to make sure I get that question right there. Okay, I don't see it here. So I think incremental improvement is good. If it's for a startup company, then I think it's much harder. It's really a licensing opportunity, which is what we're looking for in some of our devices. And incremental improvement can sometimes be great. We definitely, I think for many of you, just trying to capture that need down and in some design concepts is probably a great place to start, a great place for you to sort of discipline yourself and to just go through the process. At some point, you're going to need to get technical help, and you need to talk to a contract manufacturing firm because there are nuanced elements of the cost structures into how things are distributed, how things are used that are sometimes really, really hard to understand unless you're in that industry or sub-industry. For example, we had an endotracheal tube made out of some sort of polymer, probably some PVC. We're trying to improve placement of this tube. And we talked to a couple of contract manufacturing firms, and they're like, these are sort of penny to the dollar, like no person touches it. And so any improvements have to be really efficient for the machines to do, which is really important knowledge for us. We wouldn't have known that ahead of time. We really had to talk to a contract manufacturing firm, an engineer specific in that area. And so I think without overthinking it too much ahead of time, getting the idea down, getting some concepts down is probably as far as your knowledge can go. And at that point, you're going to need to try to find or have someone find someone who understands the space really well and how things are made, if they're made overseas or made in the States, and what materials and how they manipulate those materials. Is it injection molded or is it blow molded? Is it, where that knowledge is not obvious to find. You just need someone who really understands that to help you see if this perceived incremental improvement can actually translate to sometimes a great benefit to patients for very little, dollars. Again, I know it's a really hard answer. It's not a hard, fast answer, but there's just very specific knowledge that's, for those sub-industries of, material manipulations and assemblies that are sort of obscure knowledge that's hard to Google. You have to talk to someone.
Got it. That definitely helps. Thanks a lot. And I guess just to wrap this up here, unless anyone has any more questions, you can ask them in the question box. But looks like we're almost done. But just to wrap it up here, last question. So, it looks like some of the first people you want to talk to are lawyers and mentors. I saw that in one of your slides. But when it does come time to talk to somebody with a biomedical engineering background, if you're not at an institution that has BME department at all, and you don't know where to look for that, what do you do?
Yeah, it's great. That's a great question. And I would actually, biomedical engineering department it's a fine place to start. I am obviously a big proponent of the field. Mechanical engineering is very good. So I guess if it's more of a physical tool, something that you're a guide wire or catheter, materials, I would say mechanical engineering or materials, or even an industrial design group would be really, really good. If it's more of a biologic some sort of chemical, some sort of pharmaceutical, chemical engineering or chemistry group. So assuming it's, so that's one sort of thing. There are design firms that are usually willing to do at least a 30-minute to an hour call with smart clinicians who have ideas. And if you're able to bring a physical drawing or just a general idea, general sketch, I probably wouldn't bring the sketch to them. I'd probably talk to a lawyer first and just make sure you get some protection before you bring your design sketches. And so, talking to design firms is another one. And, I think this is a good opportunity for you to also test your network, see who's at your institution. If you're training somewhere, you're probably attached to some university. And sometimes, you have students in different engineering disciplines that can help. It's actually not so specific to biomedical engineering. I think a lot of engineering people can give a lot of guidance to this. And I mean, I think I'm also willing to, I don't know, send you towards, depending where you are, like help you out by sending you in a certain direction or letting you meet someone. I was trying to sort of rethink whether or not I wanted to say that, but I'm happy to help. If that's something that a resource, I'm happy to be a resource. And I think Rajat is talking about potential resources that this group could potentially contemplate, potentially putting together some design firms that could be of assistance to you during your training time. I don't know. I don't want to put you out there, Rajat. Sorry if I'm calling you out a little bit.
Not at all. So I guess just to follow up on that, I'll let you handle this last one as you'd like. A couple of requests for your contact information from the audience. If not, then you can definitely reach us at the RFS, and we can get in contact with David for you. But I'll let you answer that as you will.
Yeah, since this is, I'll have them contact you, Rajat, and then we've been emailing about this, and then next month I'll probably be back with my colleague from our licensing group to talk about intellectual property and sort of reiterating some of these points again. But definitely, I would say through the SIR, leadership team, they have my information and they can forward along your email very easily. Very happy to help. I really love doing this and really think, just like working with med students, that residents and trainees are, you're the future of medicine, but you guys have tremendous ideas and you see the world differently. So there's a lot of exciting things that can happen.
Thanks so much, David. Yeah, so again, if anyone has any extra questions or comments, definitely pass them on to the RFS, and we'll be happy to forward them to David for you. Again, please do keep in mind that he'll be back next month for the next part of this series. We're really looking forward to it, David. Thanks again so much for this tonight.
Yeah, happy to do it, and yeah, have a good one.
All right, everybody, have a great night.